This next case is of endovascular management of an acute internal carotid artery occlusion with stenting for intraluminal thrombus. Here we use proximal and distal protection. This case demonstrates a 40-year-old male who was transferred from an outside hospital with acute right hemiparesis and aphasia for more than 12 hours. Therefore, he is out of the window for TPA. On exam, he's awake, alert, and aphasic with weakness. His CT scan was normal, but the CT angiogram showed a left MCA partial occlusion, and the CTA of the neck showed a left common carotid artery, internal carotid artery, and external carotid artery with intraluminal thrombus. His CT perfusion showed deficits with increased time to peak on the left side with preserved flow and volume. The red arrows show thrombus in the common carotid artery, internal carotid artery, and external carotid artery. Given the fact that there was preserved flow and volume, we considered endovascular repair and treatment for the intraluminal thrombus seen in this carotid distribution. Following femoral access, we bring a VTEC catheter into the aortic arch and we hook or access the left common carotid artery. Over the VTEC, we bring our guiding catheter Here we can see intracranial run showing some filling of the intracranial circulation, but clearly there's a filling defect in the carotid distribution. With our guide catheter, we inflate the balloon to create proximal flow arrest. Under flow arrest conditions, we inject contrast for a roadmap. And here we carefully navigate a micro wire past the intraluminal thrombus in the carotid bifurcation, internal carotid artery, and external carotid artery. Here we cross the stenosis and the thrombus for deployment of the NAV6 filter. Once we're in a straight segment in a safe landing zone, we deploy this filter and get ready to bring a low porosity stent up. The key here is with low porosity stents, we're less likely to extrude thrombus from the vessel into the stent. Here the stent is unsheathed or partially deployed. We constantly assess our position. And once we're deployed across the entire span of the thrombus, we will do a run to assess the result. We will try to avoid angioplasty in order to prevent thrombus extrusion into the interstices of the stent. Once our run shows that the stent is well positioned, we bring in a second stent, again to decrease the porosity and extend the length of the coverage, given the fact that the thrombus had significant length. We are very careful to make sure that the two stents overlap somewhat to avoid any disconnection or space between the two stents. Again, it is critical that these two stents overlap somewhat. Once we're pleased that the entire span of the thrombus has been stented, we bring up our capture catheter to capture the filter. And once the filter is captured, we will assess our repair with final angiographic runs, showing complete filling and better filling of the MCA and ACA distributions, as well as no thrombus in the cervical segment as demonstrated by the CT scan. And this concludes this case of proximal and distal protection for intraluminal thrombus treated with overlapping stents.